what I'm going to talk about, so I'm Eric Zacharias. I'm a physician risk manager at COPIC, and this is the part two of our opioid information, and this is what we call case studies in opioids. And we go through kind of the next phase of opioids from the first presentation, and this goes into a little more detail about chronic use, tapering people, keeping people safe and stable for a period of time, addiction, substance use disorder, and a little bit of information about some bridging therapies as you try to get patients to a safe place with their opioid usage. So here's the CME objectives. And by the way, if someone has audio on that's got some background noise, if it would be possible to mute, that would be great. But anyway, the objectives are highly addictive, discussing alternative therapies for pain management and describing best practices to minimize the use of opioid therapy for chronic pain. There's a lot of potential downside risks to using opioids for chronic pain. Of course, I don't have the information up here. I believe your clinic is multi-specialty, but I honestly do not recall what your group is. But I do know you're in Iowa, and at least one of your football teams is doing very well. I presented in Nebraska yesterday, and their football team's not doing very well. So anyway, good for you all. So big college football fan. So here's the CDC basics, and this is consistent with hopefully what we talked about in Opioids 1, and it will be consistent. And this is the way to keep your patients most safe, to keep your practice relatively sane, and to minimize the risk of getting into dangerous situations. So pretty much any situation, non-opioids are preferred, certainly for chronic pain. When opioids are indicated, use the lowest dose. 50 is the new 90. Lower dose reduces substance use disorder, reduces risk of overdose. Let's go through the first case. We talked about CDC guidelines, talked about Iowa football, and now we're talking about cases. So the first case is acute low back pain. And this was the old school prior way, which was, oxycodone, QID, and then adding a benzodiazepine. And this is, now considered outside of reasonable practices, and, adding opioid therapy where it's not necessary, and certainly long-term therapy. Back pain tends to last for a long time. Is what leads to this addictive situation that we're in the deaths. And this is a repeat slide from last time. What has occurred over the last 20 years or so. This goes back 13 years. But as treatment has gone up, sales have gone up, deaths have also gone up. So that's the big culprit. And the reason why we're doing these opioid education presentations is not so much that people aren't aware of the risk. It's just how sensitive the national population has been to as the opioids have gone up, the risks have gone up. And what's happened over the last couple of years is to maintain for people who have substance abuse tendencies, the deaths from synthetic opioids, the use of synthetic opioids, to maintain their their opioid receptor saturation has skyrocketed, and that's been the big culprit. But it started with us, and we acted again on the Opioids 1. We acted based on reasonable information on prevailing forces at the time, recommending that that's what we do. But state legislatures, in pretty much all states, have been very active in passing guidelines. They almost all follow the CDC guidelines. It varies precisely from state to state. I know the requirements very well in Colorado and Nebraska, and again, they just they mirror the CDC, and I would suspect anything in Iowa would be the same. Also, you don't have to memorize those. Just know that if you do follow best practice guidelines, that will be consistent with those guidelines. You know, how much attestation to CME, how much upkeep you have to do from a bookkeeping standpoint. Again, that varies from state to state, and it's been a moving target. But what has not been a moving target is there's some things we do that hurt. And people who do procedures know that when someone comes out of anesthesia and they've recovered from your long-acting bupivacaine injection, if you can even get bupivacaine, there's been a national shortage of that. But if you once the person's come out of it, they're going to hurt. You know, they're not going to hurt for a month, but they're going to hurt for a few days. And the prior standard was, the common practice was to give, a substantial dose pretty much to cover 99% of your patients. And the upside is, of course, no one calls you saying that they don't have enough pain medications in that first 2 weeks. The downside is that there's substantial downstream consequences, which we'll talk about in a little more detail. Also, a repeat slide. If you look at that x-axis on the bottom there going across horizontally, that number of days, the number of days of that initial prescription has an enormous impact on the likelihood of someone being on opioids a year down the road. So that solid line, that top of the two lines, solid blue line, if you look at the difference between giving somebody 5 to 10 days of opioids versus 30 days, it basically, if you give someone 30 days of opioids, the odds of them, and this is opioid naive patients, the odds of them being on opioids a year later is 35-40%. So that's huge. And so judicious use of these valuable medications when somebody needs them. So here's some of the data on how much to give for certain types of conditions. This was a JAMA article looking at post-op patients. How many days do people generally require or need opioids? When you use these numbers as opposed to the 30-day, there'll be much fewer opioids out and about. And why does that matter? Well, it matters because the rates of misused opioids comes from prescriptions. And the longer the prescription, the more prescriptions, the greater the likelihood. And almost all diversion, I think it's like 80-85%, starts from not from buying them on the street and diverting. It comes from the prescribed opioids. So again, very judicious use of this because these will have a high likelihood, if there's extra medications, of being diverted. And this slide just emphasizes that point, looking at the percentage of people who are using chronic opioids non-medically, using them as substance use disorder. Over half got them from a family member or a friend who would obtain them as a prescription, and about 15-20%, depends on the source, get them from physicians. Again, we're a big source of diverted opioids, and again, the big challenge with that is that leads to chronic use and increased risk for abuse and ultimately death and infectious disease complications and other risks. But that's not to say everybody shouldn't refuse to prescribe opioids. This is a case of a plumber. This is a guy who represents a guy with degenerative joint disease, and this is actually based on a real patient of one of my partners, Dennis Boyle, who is a rheumatologist. And this is a patient who had severe DJD. And, he met all the criteria for a knee replacement, except for the fact that he's getting health care in a system that can stick him with substantial bills, didn't have insurance, couldn't afford it. And so as a consequence, to maintain his functionality and keep him from being on disability, unemployed. Dr. Boyle had him on a reasonable regimen of chronic opioids. So there are some situations where it's okay. So I don't want you to come out of this thinking that all your patients we have to stop opioids on everybody. That's not the goal. The goal certainly is to minimize it and reduce it. But this is somebody who had regular follow-up, stable medications, had a medication contract, and didn't have any red flags, and did have urine tox screens looking for other medications, other things that would have been a violation of that contract. So that's okay. You wish you weren't here, but sometimes that's where patients are. I've got a patient who's works in the trades, and he does manual labor of some type, and he's on chronic opioids. I mean, he takes, I think, 2 hydrocodone a day, and he maintains functionality. The same thing. He doesn't have insurance, can't afford the procedure that would be, help probably fix his pain. And so right now that's okay. For somebody like that, you definitely want to calculate the MEDs and keep them stable, keep them, on the old school would be keep them on about 90 or less. Ideally now it's 50 or less. Sometimes you wind up getting a little bit higher, but calculating that MED and avoiding escalation of the dose, that's where you really get into trouble with anybody who's going to be on chronic medications, because there will be a point where someone has breakthrough symptoms, and the therapy for that is not to up the dose of opioids, because that just winds up in almost chasing your tail. And as the dose goes up, the risks go way up for complications, and also the risk for diversion goes way up. So what can you do? And again, in most of these patients who are like the plumber and the tradesperson I talked about, it's do you need a pain management consult or referral? You might, if it's somebody like those 2 patients I described. It's really more just regular follow-up, assessing the function, making sure you have a good consent and agreement. Do the urine tox screens. That's important. That's a key part of appropriate monitoring, checking the PDMP. That is, again, depends on the state, but sometimes that's mandated by law that you have to do that, and can definitely give you some good insights on whether you have a trustworthy partnership. And sometimes you have to have that tough discussion. And the tough discussion could be around we can't escalate, and explain the reasons. And it's not always easy, but that is very important and valuable for keeping these patients safe. And we do have agreements and consents on our websites. I think anybody on chronic opioids absolutely deserves a substantial discussion about the risks, benefits, where they may wind up, and a consent form is a good way to document that thought process rather than having to elaborate in your note, although you certainly can do the note. I mean, the consent is the discussion, it's not the form. The form memorializes it, and I think it's a good way to memorialize it. So sometimes our patients will also, though, they have these 2 patients, my patient, Dennis's patient, both under 90 MEDs, but sometimes you get somebody on a really high dose. This was a patient that we've taken care of who was on much higher dose, and so this patient actually wanted to taper their dose down somewhat. And if you do a calculation on the MEDs of this patient, that patient's on 180, and that's a lot. That's getting very close to risk for, very high risk for respiratory suppression. It's already substantial risk for respiratory suppression, as well as risk of diversion and so on. Let's presume this person's actually taking that dose, has some interest, or is at least amenable to a discussion on tapering. And so you've got to start the conversation, but part of the conversation is understanding where the patient's coming from and the patient understanding where you're coming from. We have this slide to show that this is kind of what's going on in your mind, and this is what's going on in the patient's mind. In your mind, you're worried about side effects, risk of death, respiratory suppression, diversion, addiction. The patient's worried about pain. Pain is unpleasant. It really is miserable to be in pain. Opioid withdrawal is miserable. It's also incredibly inconvenient to come in regularly for rechecks, for the testing that needs to be done. And so, patients are, even ones that are amenable to tapering are, they're concerned about these risks. This is, if you do surveys, the biggest concern is, of course, pain. The second is, I'm going to be withdrawing. And the third is, do you really care about me? And it's okay to both care and want to get somebody down. So that's that's a key conversation. And so you're thinking about, how am I not going to cause harm, i.e. getting somebody to a lower number. It's gone from 120 to 90 to 50. A lot of these patients, they'll never get to 50, but you can at least get under 120 and ideally around 90 MEDs. Letting the patient know that where they have been may not be within the current accepted practice standards of care, and you need to help taper them down. Part of that conversation may be, though, they're thinking you don't care, and so it's how you express that. And so, the better the relationship, the more empathic you are in those interactions, the less likely they are to get medications elsewhere, the more likely you are to have a positive relationship. And I'm not, just a total moron. I understand that this is hard and these patients can be complicated, and it is a diverse patient population. And the idea of just saying, oh, yeah, you're going to keep them safe till they get with a pain management specialist, excuse me, I know that's not always realistic because, I don't know, at least in my community, it's impossible to get somebody in with a pain management specialist. And we have a few, and some are better than others. So, during this period of time, as you're trying to figure out the best way to keep somebody safe, maintaining that trusting, collaborative relationship really is valuable and powerful. So there's a few pearls from all of that, and I think, again, in the discussions and the interactions, the first is using the do no harm concept and strategy. And every now and then, that last one there, validating your actions by calling attention to your rights and expertise as a physician. I mean, sometimes you have to pull out the doctor card. Sometimes you have to pull out the, NP or PA card and say, hey, I've got a lot of training in this. And actually, you have to trust that what I'm doing is based on the best science, i.e. escalating doses of opioids will not result in better pain control, will result in worse outcomes. In fact, studies have shown it can result in worse pain control. So, there's a way to do that without sounding callous and arrogant. And it's a bit of an art. And, quite honestly, a lot of it depends on how your day's going, how much sleep you got the night before, what your day's been like. So sometimes it's easier than other times to be softer when you pull that card on patients. But irrespective of all that, it's very important. And if you're not good at setting boundaries, then practice. Just script it with a partner or somebody who acts as if they're an opioid patient, and just set the boundaries. And there are some people are more artful at it than others, but it is a skill that you can practice. And part of it is having good motivational interviewing skill sets where the questions are more open-ended, where you have the reflective listening, where more or less, what I hear you saying is this, and just letting the patient speak. Just what are your concerns, as opposed to, well, I bet your concerns are probably withdrawal, and that's not going to be a big deal, I promise you. That's a close-ended question. The open-end would be, tell me what your concerns are, and I can help address those. And again, most of us I think you're probably all aware of the studies that the average physician cuts the patient off after 9 seconds, I think, when you ask them a question. And if you let them talk, the patient winds up talking for 17 seconds. So, it's double the time, but the reality is it's still under 30 seconds. So most people are not going to take the ball and run with it and give you just a word salad. They'll have a very short answer. So trying that can also be, help build trust. Some of the, hope you guys are all seeing my text come in. So some of the nuts and bolts of this, if you do want to taper somebody, are go slowly. This is not something to emergency get somebody down. We're talking 10% or less a week. So that's about what a human can tolerate on tapering without having any withdrawal side effects. And in most situations, you can get down 50% or so on the opioids, and that almost always will be a safe level. And so that's where we typically target when you have somebody who's on a higher dose who you want to get down. Now the alternative therapies, there are many. Going through these in great detail, each one of these is probably a separate lecture. But there are, if somebody is on chronic opioids and has acute pain, or if they just have an acute pain, there are many therapies outside of escalating opioids or adding opioids that are highly effective. And this is becoming standard in many emergency departments where injection anti-inflammatories, trigger point injections, ketamine, nitrous oxides, other dissociative therapies, they work, and they work well. And that will be something that I think is the next generation of medical student and resident trainees come out of their programs. We work with the University of Colorado School of Medicine medical students and residents very closely, and they're getting very well trained in this area. So I think that's going to be an area that really booms in our practices, and those of us who are a little longer in the tooth, as new people come out of training into our practices, talking to them about, hey, what are y'all doing? What are you doing in 2022 for pain management? And I think we'll all learn from each other. Now, back to that prior patient on this high dose. There are some times where there are aberrant behaviors, right? So the cat ate my oxycodone, somebody who tries to frequently get early refills, terrorizes the front desk. Again, at some point, you have to draw the line with patients. You have to be very concrete, and I'm not saying it's easy, but hopefully, the more trust you have, the more clear you are that you're not going to A, violate the contract by giving them more, but B, you're not going to abandon somebody. The less likely you are to wind up in this situation. But some people have, they have severe substance use disorders, they have borderline personality disorders, and they're very, very challenging to work with. So let's talk a little bit about, the opioid addiction and people on chronic opioid therapy. How many have or develop a serious opioid use disorder? It varies, but addiction. Remember, addiction is the disease. It's the chronic disease. Being on a high dose for chronic opioids is not by definition an addiction. They certainly often overlap. And the reverse is also true. Just because someone is not on opioids, who's been on them, doesn't mean they're not an addict. It just means they're an addict who's not on opioids. And so, weaning somebody, tapering them, there's lots of health value, lots of risk reduction from that. But that does not address the addictive predisposition. And in fact, it doesn't change it. And so people who have substance use disorder, it gets a little more complicated. And we'll talk about helping manage that as well as we kind of go through this. But here's some of the criteria for the diagnosis, and this is a bit like the diagnosis of rheumatoid arthritis. You have to have a certain number of these criteria. but taking large amounts over a long period of time, persistent desire, but unable to cut down, a lot of time obsessing, thinking about trying to get them, craving them, having it result in challenges at work and relationships, and continuum irrespective of that, and the tolerance and withdrawal as well, which if it's prescribed, those aren't included in the diagnostic criteria. So opioid use disorder, out of those 11, is ranked mild, moderate, severe. But I think a simple way to think of it is, have you ever craved opioids and taken them non-medically? And almost by definition, that's going to put you at high risk for this, but you can go through the diagnostic criteria. As we talk about in a minute about some of these bridging therapies for keeping your patients safe and helping treat the keeping the volume of opioids down. Remember, opioid withdrawal is miserable. It is rarely fatal. It's not generally considered high risk, although it certainly can result in complications. But it's miserable, and it really is unnecessary suffering. So not only can it flare up underlying psychiatric conditions and probably induce psychiatric anxiety or psychiatric level of anxiety, among other things. It's just a miserable thing to go through. So the goal is not to, torture patients, get them off opioids immediately. It's to, treat it with compassion and get them down, because, again, a lot of these people are addicted or may be addicted. And so, kind of the summation of all that is just, think of addiction as chronic, a very strong genetic component. And, people with addiction do not have control. That's not to excuse all behaviors associated with addiction, but it's just to understand them. We're not law enforcement. We're physicians. But it can be difficult to treat. And again, remember, just getting somebody off the opioids doesn't treat their addiction. Detoxes them maybe, but that's not treatment. There's incredibly high rates of relapse. And so, how do you actually treat addiction? And we'll talk about this just a little bit as we kind of wrap things up here. I turn it over to questions. Is that it's replacement therapy, and we'll talk about those replacements and counseling, psychological counseling. But it's a long-term process. So remember, you're dealing with all of these challenges kind of simultaneously. They're dependent, they crave. They've been having lots of life consequences, and they don't have much control. So, an addiction is a very challenging medical condition to treat. I mean, give me just a nice, straightforward STEMI. Not that hard, right? I apologize to all my cardiology friends, but, addiction's harder. I guarantee it. I'd rather treat a STEMI any day than treat addiction. So, again, tapering is important. Getting doses lower is valuable, but getting people completely off actually does not improve addiction treatment. It does not improve long-term outcomes, and actually it increases the risk of relapse. Our friend borderline personality disorder, we can't really have a talk about addiction without throwing in a little bit about borderline. I'll just say it just makes it that much more. Difficult. I get that, and a lot of patients who you'll have in your practice, have that as well. So again, not lost on us that makes it challenging. So what do you do? What are the medically assisted treatment options? I said, okay, you don't have to get patients completely off. How do you keep somebody at a stable, safe, bridging level who has addiction, substance use disorder, while you're trying to get them to somebody who's an addiction specialist plus minus a pain specialist? Methadone, you really have to have a special center for that, but it works. The other ones that are available, naltrexone, buprenorphine, those are one that some primary care docs are doing. You definitely need to train in them. They're not incredibly complicated, but they're not just straightforward, like, lisinopril as a new blood pressure medication. There's a little more to it than that. So, getting trained in those. But there's a lot of advantages, especially if you have a fair number of patients who are going to be on, opioid maintenance with their substance use. Remember, you got to keep them stable. We're not going to escalate the doses, but with the maintenance therapy, they're less likely to turn to illicit drugs, street drugs, injection drugs, these synthetic drugs, which the concentrations of opioid agonists are very, very highly variable. Of course, the criminal challenges and the viral infections and so on, the endocarditis from the injection. So there's lots of upsides to opioid maintenance, and that's really considered the standard now, because detox is really, really hard. And these, buprenorphine especially, probably helps suppress the predisposition to anxiety and psychotic symptoms. A little more data on there about reduced risk of death. So again, patients who are on these medications, methadone and buprenorphine specifically, much lower rates of death. About a third to a quarter methadone, and about half or less with buprenorphine. So the mortality does plummet with these if you use that as a therapy. Again, back to our friend of opioid withdrawal. Why are we trying to avoid that? Because it's miserable, and if you don't bridge, if you don't have those other therapies going, people who have withdrawn from opioids once will do anything to avoid it again, and that includes all kinds of very high risk behaviors, not only for them but also, perhaps for community safety as well. Very unpleasant symptoms. Just kind of showing the mu opioid receptor activity of these different therapies. Naltrexone, basically none. Buprenorphine, modest. Methadone, quite high. So it keeps those receptors saturated, as well as affecting the brain chemistry. Last check, there are about 22 methadone clinics in Colorado. I don't know what Iowa's numbers are, but I'm sure you're way underserved like the rest of us. And you have to have special training and work in a special facility to prescribe and follow that. Buprenorphine is great because, again, if you train in it, you can do it in primary care office. It helps you just kind of smooth and settles things with people who are chronic users with addiction, and it does reduce the risk of death. It does work very well as you're trying to get somebody into counseling and therapy. And remember, addiction is a lifelong condition. If you're going to use these medications, HHS has a great guide on its website, and it's called the HHS Guide for Clinicians on Appropriate Dosage Reduction. It's a really, really good site, so I would encourage you to seek that out. Just real briefly, I'm going to wrap it up here at about a minute, and then see if anybody has any questions. And I really hope that the AD is working here. But with the other drugs, it's very important for the tox screen. They're almost always additive. There's never been a study that shows if you add marijuana or benzos or cocaine or I don't know what else people use, but any of those drugs, they're additive. They don't taper the opioids, so people stay on the same dose of their opioids plus they have those. So there can be, a substantial increased risk of side effects and complications. And again, if just because you're addicted to opioids doesn't mean you can't be addicted to other things as well. Marijuana, again, it's additive. It's never been shown in any trials to result in reduced use of opioids or better pain control. So that's why it's screened for, and recommend people not do both, because there are, again, additive risk. It's not exponential additive like benzos. Benzos, it's synergistic. The complication rate skyrockets, about tenfold, 4 to 10. I think it's more like 10 of overdose death if benzos are co-prescribed with opioids, and that's why that's just considered something to avoid, maybe not at all costs, but as much as reasonable. And it is a black box warning, and you should document if you're prescribing the two together. See if I can get through this quick. I'm going to skip that. Basically, use low dose. Oh, I got 2 slides left. Yeah, so naloxone for all your chronic opioid patients, anybody with high dose, large numbers. Naloxone for the patient and the families. Make sure people know how to use those. Very, very important. Refer for substance use treatments while you're keeping them safe. Care for them as you keep people at a reasonable dose. Abandoning patients is not going to result in better outcomes. They are going to seek out opioid therapy from street drugs and put themselves at very, very high risk. And I think those are the key points. I apologize for the challenges at the start. I will open it up for questions, and hopefully the audio will work. Let's see what's on my screen here. Okay. Does anybody have any questions? I got the chat pulled up as well. Can y'all pull your audio up if anybody has any questions? You don't have to have questions. We can talk about football if y'all want. Although you're in Ames, I think Ames is Iowa State, yes?
Yes.
Well, I'm from Starkville, Mississippi. We're in Mississippi State. If one more person tells me I'm Ole Miss, I'm going to strangle them. So, different schools, different town. I got a chip on my shoulder because of it. Maybe y'all do too. I don't know. Well, I'm going to assume that means you have the information that you need and that you're rushing back to clinic or the hospital, or maybe you have the afternoon off. Get out there, enjoy the beautiful fall weather, and again, apologize for the beginning. We used the same system last time and it was smooth, and this time, I apologize for those of you who had to witness the beginning, but I do appreciate your attending.
Well, thank you for presenting again. We greatly appreciate it.
Okay. All right. Well, and good happy Halloween. Don't forget Halloween. It's coming up. Buy your candy.